this is one of 2 workshops. They're going to be conducted by Kurt. We will have public comments. Those public comments will be at the end of the meeting. If you have not filled out the form that you entered in, you will not be allowed to address. And then, as Kurt goes through it, hopefully we'll answer a lot of the questions that you may have, and then we will end with the workshop. Kurt?
Okay. So, first of all, I want to just go over the purpose of the meeting so there's a direct understanding as to why we're meeting here today, what the purpose is, and then we will plan a second meeting that follows up where we have considerably more information on the pillars. So the purpose of this particular meeting is to evaluate our health focus areas and discuss what information and data trustees want us to gather to evaluate and identify the most important health focus priorities for Marion County. And so I won't use health focus areas from this point on. Let's assume it's synonymous with pillars. So again, the end result goal of today's meeting is to get information to staff regarding what information you are going to need, and I'm going to cover some of the information at our disposal and data. And if you need anything additional, let us know, and staff and our consultants will evaluate what information we need for the next meeting. So the next meeting, we will have a facilitator, likely Jeff Feller from Well Florida Council, who is our population health expert, and he will go through the data, and I'm sure he already is very familiar with the population health data for Marion County. And then also we will identify gaps from various sources that I'm going to go over, just so we have a general understanding about what information is at our disposal. And then we will also determine what information we need as part of this to consider homelessness as a potential health priority. And once I finish with a general overview and some background historical information, then we will have an open discussion with the trustees to discuss what information you would like us to bring to the next meeting. So just as a general reminder, in 2015 we developed our initial health pillars or health focus areas. We derived that based on research by Well Florida Council and our available community health assessments, which is a compendium of information that is put together by a group of medical professionals, nonprofits, federally qualified health centers, and the hospitals and the hospital district, and a wide swath of the community to identify what our gaps are in Marion County. And a great part of the community health assessments that are done at least every other year is at the end is an appendix with a significant amount of data and sources for us to utilize as part of our research for looking at our current health pillars and identifying what new health pillars we might want to consider. I also want to point out, as I go through these 5 current health pillars, which are mental health and substance use disorder, and you'll hear me use the proper term behavioral health and substance use disorder throughout this presentation, dental services for the uninsured and underinsured, and removing barriers to access to dental care, diabetes, obesity, and use of tobacco. So those are our 5 current pillars, and I'll also go through this with just some basic discussions about some historical discussions we've had about blending some of these pillars together that we can also consider at the next meeting when we discuss the our next phase of pillars. So what resources do we have at our disposal to identify needs and gaps? I just mentioned the community health assessments, which are typically the most current information and most accurate data we have specific to Marion County. And then also community health improvement plans. We'll also have some suggestions regarding strategies to tackle those pillars or focus areas for health. We will engage Jeff Feller, who is a public health expert who's helped us at least since 2015, not only to identify our current focus areas, but also Jeff is a graduate of the School of Public Health at University of Florida, and he also teaches at the Graduate School of Public Health. So he tends to be on the forefront of available data for Marion County and for trends throughout the state and solutions that other counties have used as strategies to tackle those health needs. We also have data from Robert Woods Johnson, the Centers for Disease Control, and the Florida Department of Health as some of our key data sources to bring to the table at the next meeting. Some other things that staff will bring to the next meeting is mortality data and information regarding years of potential life lost, which I'm going to give a definition for, and why it's so important for us to evaluate years of potential life lost, because communities that tend to develop solutions for their health gaps, they tend to focus on what causes their citizens to die young. And that's where years of potential life lost comes into play. We will also identify and have available chronic disease data, the most current that we can find, that's not based on behavioral risk factors, and I'll go into why that is. And then also correlation data. We'll have as much as we can that we feel is valid for the discussion, and if you want more information, just let us know. But the correlations between abuse, homelessness, income, education on the impacts of premature deaths to citizens of Marion County. So we can have a valid discussion about our most critical needs in Marion County. So one of the backgrounds, just for education purposes, is definition. When we first started off, a lot of individuals were focused, not here at the committee, but the committee was focused on leading causes of death versus years of potential lives lost. And I'm going to go into just a basic primer on this as to why this information is important for our next meeting. So first of all, you can see based on the most recent data for Marion County, the leading causes of deaths are cancer, number one, heart disease, and then accidents. Now this is just based on the sheer number of individuals that pass away from each particular cause of death. So there's an assumption on a lot of the models for mortality that we're going to assume that men and women should live to the age of 75, and if they don't, then they're dying prematurely. And then we can start looking at the causes of that. So based on this right here, it doesn't tell us a lot other than what people died from. They could have died after the expected life expectancy. It just shows a sheer number. Now let's contrast that with something that we had found previously, which is this flips around when you look at what causes our citizens to die young. And this is a national average. And this has been true our 8 years of developing programs, where it really flips, where the leading cause of death, another term for accidents, is unintentional injuries. So the number one cause of our citizens dying young tend to be, and it has been true for the last at least 5 or 6 years that I've been evaluating this data is unintentional injuries. So this is something that I want to bring to the table that we can see, and we will have a deeper dive regarding the most recent data as to what causes our citizens to die young. But in just an example, so Robert Wood Johnson looks at mortality rates for every county, and they look at these factors. And how they look at this is, if someone has a heart attack at age 74 and they pass away, that's considered 1 year of potential life lost counted against your county in their ratings. If an infant passes away from a drowning at age 1, that's 74 years of potential life lost. So that helps you focus on what causes your citizens to die and lose the greatest number of years of potential life lost. And it's an indicator that counties that develop programs, they tend to focus on areas where their citizens are dying young, and they come up with remedies. So it's just one of these things that we want to bring. So number one on the list is often poisonings, which also includes overdoses. Motor vehicle accidents are typically high within this category of unintentional injuries, drownings, suffocations, and falls. And falls are an interesting one because that vacillates where it sits in the unintentional injury range based on the age of your population and the impact of that fall. So this is data that we'll bring to the next meeting. The other thing I wanted to point out is something that some of the trustees have gone through, and we've evaluated this during our strategic planning sessions, but we have some newer members that may not have seen this. So if you look at this column right here, we have health behaviors, clinical care, social and economic factors, and physical environment. So these are the factors on the spectrum where it shows the percent attributed towards mortality. So the highest factors that are related to mortality, the biggest factors, are social and economic factors, what we would call social determinants of health. Education, employment, income, family and social support, and community safety. Then next on that list is health behaviors, and we have several programs related to addressing these. Well, actually, let me go back to social and economic. We have one right now that has a tie into social determinants of health, and that's Community Home Project has a major role in improving the health through improving education, income, and employment, as well as working on direct diabetes education and nutrition and physical fitness. So next is health behaviors. Tobacco use, we already have that as one of our key pillars. Diet and exercise, we have Active Marion Project, very large scale projects, Active Marion Project, and also we have multiple partners that are working with us on diet and exercise. Alcohol and drug use, we have numerous initiatives related to that, including our, $6.4 million or so towards behavioral health and substance use disorder that we invest. So we make a significant investment in not only tobacco use, which is an addiction, but also alcohol and drug use. And then the next factor that has the biggest impact on the length of life is clinical care, access to care and quality of care. So a lot of this, so quality of care we try improving, especially for the safety net. For those that don't have access to quality care or cannot afford care, we've been working with SMA and the federally qualified health centers on ensuring that they have the highest quality care for behavioral health, substance use disorder, dental, and primary care. So that's, you'll hear me refer to safety net in regards to individuals who do not have the ability to afford quality care. And then lastly is physical environment and its attribution towards mortality or length of life. And this these are general factors. These can change over time, but they tend to hold true year after year. This was developed by Robert Woods Johnson and the community health rankings that used to exist up until a few months ago. And so we're going to bring data related to this just so we can see, again, what is affecting length of life for our citizens, and are there gaps in services to the next community. So we're not going to talk strategies today, we're talking pillars, focus areas. But just for general education, so we understand what the difference is between health focus areas and strategies, we have several things that the hospital district has done to this point. Major projects, these tend to be large-scale, high-impact, multi-year projects. Active Marion Project, Fitness and Nutrition in Schools, Beacon Point, large-scale, impacts a high percentage of our citizens. Then we also have strategies that we've used for providing gap funding or crisis funding, such as when COVID hit and the hospitals, the federally qualified health centers, and the local doctors could not gain access to supplies or funding because the state and feds were still working on mechanisms to get funding to the communities so they can increase their supplies, particularly for the gowns and masks and gloves and the booties that they needed to change every single time they go from room to room to protect our citizens. So we provided that funding, and so that was a strategy that we used. Also, demonstration grants. Demonstration grants just was a strategy that we used really to test a new concept, a new provider, a new innovation. Tends to be on a much smaller scale, and we would determine whether or not that organization had the capacity to collect the data, operate efficaciously, and also what was the return on investment? So was it the best solution for that health issue that we had? Or was it really not scalable because the cost per client was so high that there were alternatives that may be more efficacious? Another strategy that we started employing was looking at the capacity of organizations. Which organizations had the greatest capacity to impact the largest number of citizens? That's when we started working with the SMAs, the Marion County Public Schools, the Developing Beacon Point, and the College of Central Florida. So we had organizations that had high capacity, they actually brought resources to the table, and we were expanding their capacity so they could impact more citizens. We also employed, and this has been more in the last 3 or 4 years since Deborah came on, and we started focusing heavy on, we have a finite amount of resources that we can use every year. How can we draw down additional services and dollars to Marion County so we can impact more citizens? So we started focusing on identifying new revenue sources and matching funds so we can pull down funds from either the state, feds, or from other entities. And we've done a pretty good job on that, and that's been a good strategy because that's a way that we can continue to expand services and expand our footprint to serve more citizens. Another strategy that we employed was we would look at projects in terms of, and this is one that Rich would always identify, such as, is this offset funding or is this increase in services? And that was really a good strategy for us to have, because what we found the hard way was sometimes when we invested in a project, or if we invested in a new pillar, that it would actually cease or reduce funding from the state or from the feds. And so we had to start looking at that. Is our involvement in our investments in a project actually going to reduce funding and make it so we're just replacement funding and not increase in services? So that was a very good strategy that we took on. And then lastly, looking at what modalities do we have at our disposal. As I mentioned before, we have projects, we have grants, we've expanded facilities, so that's capital expenditures. One of the most important things is, we've been able to work with community partners where there is no funding involved in our relationships. We have a dental consortium, we have a diabetes consortium, and it's an opportunity for us to really work together to identify pockets and gaps and strengths for each organization and that has really worked out for us to be able to expand some of our services. But also ones like Department of Health, they bring resources to us, they work on diabetes education. So they don't entail any funding from us, we just collaborate so we can expand our services. And then lastly, I don't like using the term grant writing, it's really fund sourcing, because anyone can grant write. It's actually sourcing funds to projects that we need, and that is much more strategic, because you have to, first of all, let's say Lutheran Services, they've invested a lot more into Marion County, Department of Children and Families for behavioral health and substance use disorder. You can't just raise your hand and say, we need more funding. We did that in the beginning, and they said, well, you have to improve your quality, you have to have a continuum of care, you have to have outstanding service providers, because you have to prove to us why you. Because they oversee 33 other counties, and we have to be able to show them, and this isn't pie in the sky, we've already shown you that we have the capacity to offer high quality services with the funding you provide us, and we can be innovative. So that's what we do. We first develop something and we go back to them and say, this is very successful, what do you think of the numbers? Would you be willing to invest in this, like Beacon Point? And they've invested, I think, 40% of the funding for services at Beacon Point comes from Lutheran Services, so that's been significant. Just a quick review, and also now that we have an audience, they can see our current health pillars, our health focus areas: dental for uninsured, underinsured, and working poor. We have here one of our dental clinics run by Freedom Clinic, and they can see anywhere between 30 people and 150 people, depending on the format and location of the services. And actually, Crystal, do you know the number for dental? How many total people year to date?
So between Langley, Freedom Dental Clinic, and Heart of Florida Pediatric Clinic, they have seen 1,991 clients this year and provided, this fiscal year, that's October 1st through actually yesterday, and provided over 8,000 dental procedures. So that's x-rays, that's extractions, that's anything you might go to the dentist for.
Yep. Our projects really fall into that safety net category, ensuring that there is access to care and that cost is not a barrier for citizens in Marion County. That includes our Freedom Clinic initiatives, Langley Dental Bus that we fund, the College of Central Florida's Dental Hygiene School, and also Dental Assistance School, that we built their facilities, and we also help them with starting off their curriculum. And the great thing about that is, especially for dental hygiene, a lot of federally qualified health centers and Department of Health utilize dental hygienists as part of their services. So we're going to have our first dental hygiene school. So this is really a significant improvement for Marion County, having access to our own homegrown dental hygienists. And then also the federally qualified health centers, through the low-income pool funding that we provide for the federally qualified Langley and Heart of Florida, they provide dental services through some of our LIP funding, especially for uncompensated care, for those people that cannot afford care, citizens. Just another big Freedom Clinic. This was pre-pandemic. Now, and it's interesting. So we started off with the big mega clinic where they saw 1,200 to 1,300 citizens that would wait in line for, all night in order to get dental services. And then we asked them to take the show on the road so we can improve access to care, so they spread their footprint around. And then they've done that even more so. So now they're working out private dental offices and with dentists who are donating their locations, their staff, their time, and providing free services as part of these clinics. And they can see 30 to 50 people in a clinic. And they have these much more frequently. How many total clinics in a year?
Total clinics in a year? I don't think I have that.
I think-
but I can look for it.
So total clinics exceeds the number of days in the year. I think it was over 300 something.
I think it was over 300 because they're counting each dentist hours of the clinic day.
Right.
So they were able to provide a significant amount of clinics.
Yeah. So we're, again, improving access to care and making it more available and more convenient for citizens to get their care. And then also the old bus, but this is one of our projects, the Langley Dental Bus. There's 2 operatories on there, and they will park outside of several of our community partners. And this one happens to be at Beacon Point. And so Beacon Point, that specializes in behavioral health and substance use disorder, we also have wraparound care for primary care and dental services right there on site, so we can take care of the whole person. And because one of the things that we found early on was that when we're questioning individuals coming in for the dental clinics for freedom, as part of the questionnaire, we were asking, how have you been taking care of the pain? How long have you had it? A lot of them would say over 6 months. Have you been managing it? Drinking or drugs? They've been self-medicating. So we saw a direct correlation. That's why the dental bus is now with our behavioral health services.
Kurt, if I could, I would just add at CF, the hygiene school.
Yes.
They now have the ability to create crowns on site as well. So they're not just providing services, but they're actually replacing teeth for during those extractions.
That's
Freedom
good.
is doing that as well, so now we have multiple agencies with the ability to do that. Instead of just pulling a tooth, which has happened previously, they're able to save the tooth and do something.
Their goal is to save the smile.
And implants.
And
They
implants.
have 3D, whatever.
That's a good point. Thank you. I appreciate that. So then our next pillar, behavioral health and substance abuse services. We have, as part of our projects, again, within the safety net, Beacon Point that we developed, which is a comprehensive system of care with multiple providers providing inpatient care, detox, residential care, medication-assisted treatment, outpatient counseling. We also have biopsychosocial assessments, the dental that I showed before, psychiatric med management, and
DV outreach.
DV outreach.
Domestic violence outreach.
Yes, so we just added that to the campus. So it's a one-stop shop, and the great thing is we have multiple providers. However, we can do a warm handoff from provider to provider and say, we're going to get you the care that you need, and we try to do our best to make sure that we don't lose people in the transition as they're improving or staying in therapy. We also provide match, but the maximum match, that's why I put match plus. We put the maximum match towards our community-based care provider, SMA, so they can draw down maximum dollars for Marion County. And as I pointed out before, when SMA took over, they received from the state total to serve our community about $9 million. And after about, 3.5 years of them providing services, we've been working with them with DCF and Lutheran Services, and without our funding, our $6-point-some million, it looks like their allocation will be about $21 million from the state. So a significant increase in services to residents in Marion County, and we were also able to increase our number of peers. So peer recovery support specialists have been integral to keeping people in care and getting them into care for behavioral health, and particularly substance use disorder. And what I found out was we have 14 peer recovery specialists that either we fund or Lutheran Services funds. And I believe that's about twice as many peers as Volusia County has, that has had peers as part of their network of services. And we're really moving ahead, because this has been beneficial not only for the programs that we support, but also for the co-responder program that the governor put into place, that we started in Marion County. And then lastly, our projects, detox beds and crisis beds, detox beds in particular. When SMA took over, we had what we call 4 community beds. And community bed means that is for people that don't have insurance. And we now are at least 18 beds between Beacon Point and at SMA. So we've significantly increased capacity, because before, why we got into behavioral health in the very beginning was first responders came to us and EMTs saying, there aren't enough beds, we have to send out our staff and our professionals out to other counties, and they have to spend the entire day looking for a bed for them for detox or for residential services. Not anymore. We have capacity in Marion County for both residential, we call them, there's 4 stages of residential. Residential 1 is what we have at Beacon Point, which is the highest level of residential after detox. And so we have that. We have the first residential 1 beds, and we added 7 of those. So not only do we have 18 detox beds now for uninsured or underinsured, but we also have those 7 residential 1 beds, which have been very beneficial to treatment. Some of our current partners, and also we work with Ocala Police Department on Amnesty, which is a major component. That's a collaboration between the hospital district, Ocala Police Department, and SMA to treat people who say, I want help, I'm going to give up my drugs. They go to Ocala Police Department, they call up SMA, and they get the person into treatment, and we help fund that. So our partners at Beacon Point are SMA, LifeStream, Heart of Florida, Langley, and Domestic Violence Outreach. Am I missing something?
Our Well Florida Council does the nurturing substance exposed newborn. They go into the homes and they provide parenting and other things.
Yeah, they have residential nurses. That's a good point. So substance exposed newborns are actually in the largest building, bottom left, along with a lot of our other services. Diabetes, obesity, I'll quickly go over that. So we have our major projects, fitness and nutrition in schools, Active Marion Project, Community Home Project has a component of diabetes and obesity. And then also our investment in the Mary Sue Rich Community Center. That was one of those ideal windows of opportunity for us to provide access to really a state-of-the-art facility. I have a picture of it. On the west side of Ocala, and if you haven't been there, you have to go. It's truly amazing, the collaboration between us and the city to get that facility up and running. The city provides the operations, but we provide diabetes education and nutrition programming and physical fitness programming at the Mary Sue Rich Community Center. That's part of our agreement to participate in building the facility. And I won't go through all those, but fitness and nutrition in schools has just been very successful. The goal was to roll out increased physical fitness and nutrition education into the school systems. We're now in every single Marion County public school, impacting, 45,000 students?
45,651 is the enrollment rate for Marion County Public Schools, and we are impacting each of those students at least once, because we have 62,481 impacts within the school, which includes health education classes and everything else that you see up there.
Yeah, and then we expanded over the last couple of years into some of the private schools also, because we saw the success of the education and increased physical fitness, and so we started bringing those into the private schools. And one interesting thing, as part of this, we built at several of the high schools state-of-the-art greenhouses, and they actually produce at the high schools produce that goes directly into their cafeterias. The healthy food directly grown from the students, and including education about healthy food options. They're actually participating in bringing from the garden directly into the cafeteria the healthy foods. And there was a period of time where, I think it was last year, when they ran out of lettuce. They could not get lettuce for the cafeterias. Guess where they came from? Our greenhouses. So it was really a tremendous opportunity to ensure that they got healthy foods at the middle schools. So we have multiple modalities to reach the students and fans, and I won't go through all those, but I listed that, and if anyone wants this, I'll send them a digital copy. Just graphical representation. Is that Vanguard on the left? I think that's Vanguard, yeah. So, we have our hydroponic gardens and and then top right, we have our raised bed garden where the students come out and they participate in planting, and it's part of their curriculum in other classes. And then bottom right, an example of the taste test. We involve the kids so they can give us input. What did you like that came from the cafeteria from the healthy food options? And what should we not replicate? And we share that information between schools. Active Marion project, this has taken off very well. Considering that there's really 2 people at maximum capacity who are working with improving education about physical fitness, working on quarterly fitness challenges. We're at least 40 employers to date. I can't remember how many locations. Is it 130? I think it's 130 locations. And the quarterly fitness challenges have been one of the most important facets of getting people tied into increased physical fitness with a built-in healthy competition using our proprietary app, the Active Marion Project mobile app. And, we have champions out there. Ben, are you still here?
Absolutely. I'm just going to say we're beating Bellevue. We will be taking that horse from them pretty soon.
I have to tell you, this is exactly what we're looking at from the get-go with Active Marion Project, is to get ambassadors that are tied in social media and really have an impact on influencing people about healthy options, not only for nutrition, but for physical fitness. And he took it and ran with it, so thank you, Ben. We really appreciate you.
Let me say one more thing.
Yeah.
We are up for 2 national awards for AMP right now, for the work we did with the bus drivers of the Marion County Public School System and
The diabetes education.
the
process.
diabetes education program. So that's a big deal.
I just learned that today. So, and then also, as part of AMP, there's a significant component to diabetes education. We have 2 phenomenal trainers that are very experienced in the deep diabetes education classes, and we also work with Advent Health so we can actually track pre and post, so we can see not only what education do they gain, but what does their blood work look like before and after going through the education. So we're trying to collect our own data on population health. And then Community Home Project, this is one of our newest projects that we developed, and this has numerous components, including social determinants of health. How do we improve an individual's life? And we do case management, evaluate their situation, what do they need to improve their education, their income, but also provide them during that time period with healthy food options, healthy shopping, and our staff helps them with actual grocery shopping and grocery lists so they can see what healthy meals look like, and meal plan, but also work directly with our partners on educational advancement, medical services, dental services, credit repair. So this is really taken off well and has been accepted well in the community. And lastly, capital expenditures like this, I mentioned Mary Sue Rich Community Center. This was their initial rendering, and it actually does look a lot like this in the end, almost identical. But this is where we have access to individuals who we might not be able to reach just through our programs, where we have access to the individuals that are coming in from the community and utilizing this free services and free facilities at the Mary Sue Rich Community Center. And so it gives us opportunities. I think some of our largest diabetes classes and most successful have come out of the Mary Sue Rich Community Center. So it's really taken off well. So I just wanted to give you some background and go over not only what our pillars are, but what strategies we've used in the past. So for the next meeting, and we're about to have the open discussion with trustees, I gave you some of the tools at our disposal and data that we can bring. Is there anything else that you want us to bring to the next meeting so we can have a deep dive discussion on existing pillars and new pillars?
So we'll open it up to the trustees.
So when, sometimes, too many statistics, sometimes you get bogged down in statistics and you're actually looking at too much, sometimes. And sometimes you're looking at secondary causes instead of primary causes, like drug overdoses, accidents, poisonings. If a guy is on opioids and it's 11 o'clock at night and he's homeless and he walks across a pond and he gets hit by a car, did he die of head injuries? No, he died of homelessness, substance use disorder, right? That's really what he's done. So when you look at the statistics of, how much of it is coronary issues, how much of it is overdoses, how much of this and that, I think it's more important to look at the populations and say, well, are there populations that all of those things are in, and maybe we can mitigate those issues by helping that population? And I think that's where the homeless side of it comes in. The average person is 75. The average homeless person is 64. And that's the average. So that's 11 years of life lost every single homeless person. Mm-hmm. So if we're going to impact the total population, and we get measured by that, right? That's how the measurement is, how long people stay alive. And if these people are dying 11 years younger than everybody else on an average, then you would think that you would look at that population and say, how do we get them not to be homeless? So the solution isn't just giving them a bed and with no barrier, and whatever they do. That's kind of that housing first thing that I'm not sure I buy into. But putting them into a situation where they can get a bed, get self-esteem, get a job, get feeling good about themselves. It's the same thing with decoupling. Detoxing a person is not going to keep them off the drugs. It's just not. It's going to get them physically no longer addicted, but it's not going to get them off of what they have is despair. Most of those guys have no hope and they have despair. So they really don't care if they die tomorrow. That's really not a terrible option for them. I'm alive, I'm dead, I don't know. So I think if we would look at homelessness as a population that has a tremendous amount of mortality issues, we may be able to cover a lot of those bases on one holistic idea. It's the same thing with prisons. For every year you spend in prison, you lose 2 years of life expectancy. So if you're in prison for 10 years, you're probably going to die at 55. That's just a fact. That's the statistics. So if we look at the homelessness, and so then you look at those two and say, okay, so how many homeless have been in jail? 100%. Right? So you're affecting the people that are dying early because they're in jail or prison, and you're affecting the people that are dying from these secondary issues, a heart attack, diabetes, overdoses. Those are really secondary to the mental health issue of homelessness. And that's why I think we really need to take a look at augmenting as a pillar.
So one of the things that I was mentioning before was that at the next meeting, if you're okay with that, we'd like to bring the correlated data that you were just talking about. So whether it be homelessness or abuse, that we bring that data that shows how it impacts mortality.
Okay, good.
Yeah.
Yeah, you know, I'm always leery of statistics because I can get statistics, see what I'm saying? You know, I mean, statistics are such a malleable way of looking at things. But, I mean, as long as we look at them, you know, openly and not from a particular perspective. Sometimes we get stuck looking at things, you know, from a perspective that's not necessarily correct. Teen pregnancies are given condoms. Okay, maybe not. Maybe that's not. Maybe abstinence is like it. So that's nothing to do with this. But I'm just saying the way people look at statistics or the way they look at mitigating these issues is not necessarily true. But what is true is homeless people are dying a lot earlier than everybody else, and we get measured on how long people live.
So my question is, we have 5 pillars that we're working on. Do we create a new pillar just for this? Or since this obviously seems to be more a problem where we're dealing with people with some issues, mental or physical issues, and do we tie that into where we're spending money for mental health and that? And then when I think about that, does that mean we steal off of the other 4 pillars because we just made this pillar fatter? I think we really got to look at, if we do it by itself, it's really going to definitely draw off because it's got to have its own percentage.
So let me just make sure I'm understanding what you're saying. I can talk loud. You're saying, do we take what we're already doing in our other 5 pillars toward helping the homeless, the things that go to the homeless population, out of those and make it into one pillar and take away from those?
So that's what I'm asking the question
Okay.
out there. I'm throwing it out there because we could add a 6th pillar and say, yeah, we have it. And it's a thing, it's an entity unto itself. Therefore, we're going to give it X. Well, that X is still
And
going
that
to come
takes
from
away
someplace.
And that takes away from the other.
So the thing is, if we already have something that's dealing with mental imbalance or problems, substance abuse problems, and we know that that's a driving force on what we're seeing, do we just pull that into that pillar? And so we're still going to end up having to remove monies from other places to compensate for what we're trying to do, unless we can find some way that we're going to end up coming with a whole bunch of money that's going to handle just that. So I don't know whether we tie it in or do make it separate so that you can always look at it as a separate entity.
But the pillars are not defined percentage of money spent, right? Those funds are fungible, right? Those funds can be moved anywhere they want to be moved, you know? So, do we need another pillar? Probably, in my opinion, no, but I think some of those there can be combined. You know, like obesity and diabetes.
Right.
The correlation between those two is pretty close, right? So maybe those two get put into one. The important point is that it's recognized, the important point is, in my opinion, is that it's recognized as a serious issue and not something on the side. So, you know, I'd love to see it as a pillar on itself, but, you know, I don't know. Or I do know, though, that we should be looking at that as an area, as a focused area, however that gets defined, in my opinion.
Michelle?
Thank you. As Kurt was talking, I did make a couple of notes, and I think it's important to put this out here to give acknowledgement of what you've been able to accomplish in the last 10 years. The hospital trustees have shown immense wisdom in your financial investments and your community investment to impact the health and well-being of Marion County citizens, and you're starting at every level. In grade school, all the way up into the aged, and not only that, but you have put sustainability programs in place to carry on for generations. And every one of the pillars that you have touched, you have, and again, in my outside witness of this, you have looked to see where are the gaps that impact these pillars that you've chosen. And then you've come in and you've provided that help to get a better outcome for the health and well-being of Marion County citizens. If you're going to continue to think about, okay, is homelessness something that you want to look at, I would encourage you to perhaps think about also looking at the continuum of care, which is the overarching umbrella for all of the service providers that provide all these services to the homeless. And then determine where are those gaps in the service provider level, and where can you come in to help prop that up to provide assistance to the service providers that's going to have a big impact. If you want to take on homelessness and become a service provider, then you would add to sitting like those in our audience today that do such, again, wonderful outreach efforts today. But you may be able to just provide more help to them to have the impact on the homeless population that you want to see happen.
Yeah, I don't think we have any interest in being the provider.
I don't know, I just am providing that input for you.
Yes,
I
thank
don't
you.
want to let's get out of the house, but I do it. But I really don't think that was the intention. I think the intention was exactly what you're saying, where we collaborate with the partners in the community and see, like how we've been giving out the money for the last 10 years, right?
Well, and I can say, I have sat on that continuum of care since 2016. And we had, since I was elected, as the elected official to the continuum of care on behalf of Marion County Commissioners. And we had, I personally have witnessed, we had to do better. We changed the lead agency. Now the county and the city are co-partners in providing this service. The Board of Governors oversees dollars that come in through our community that then go out to these service providers, and those dollars are allocated based on a rank and review by the service providers that make up the membership of the community. But as I'm sitting there yesterday, as we were analyzing ourselves, it was very clear we have a lot of service providers sitting in this room. What we don't have is the private population that provides jobs to help people move out of where they are. We also identified that we need more case management in these service provider programs to help people stay from becoming homeless, because the goal is to make homelessness rare, brief, and non-recurring. Well, how do you do that? You make sure that they have the financial stability to stay housed. That takes a lot of effort from the mental well-being piece of this, the physical, the environment to make sure that they can have a home, but you can't have a place to stay if you don't have a way to pay for your rent and your electricity and all. So I'm thinking there is a big gap that you could look at in getting more people associated with sitting on that board to help really make a difference.
Thank you, Michelle. Harvey, Dave, anything?
When we first were sitting here, 6, 8 years ago, and first had our first strategic planning meetings to discuss strategies and pillars. One of the first things prevention versus treatment. And, you know, it was just, in that general discussion, it was like, well, if we can get upstream from the problems that precipitate these issues that result in years of life lost, if we get upstream from that, then wouldn't that be smarter than just, you know, doing treatment? So, I don't say that, I'm not saying that our treatment programs, our partnership with Art, Florida, Langley, anybody else is not a good thing. But it was our thinking at that time, is there some way to get upstream from these problems that might result, it could take 5 years, it could take 25 years to see, as Sam McConnell would say, the needle move. That's very, I mean, this whole thing sometimes it can be, you scratch your head and go, well, where should we really direct our resources? In this homeless, smaller population, I think there's some opportunity there. As Rich said, they die at a younger age on average. There's some opportunity there. What would really be the strategy? Would it be somehow more prevention of homelessness, Michelle just mentioned, to try to get upstream from what precipitates homelessness? And, you know, probably these determinants, education, social determinants, and employment is a huge one. So, a couple of weeks ago, and I've been hearing about this place now for a couple of years, Wear Gloves. It's a nonprofit off of North Magnolia. I went up and took a tour of the place. Guy Ken Caberle and his wife Wendy run it. And they're pretty much all about employment. And they're giving people jobs that are not as employable on average as most people would be. They have, you know, they've been in prison, they're challenged with whatever issues. And he has got some sort of, his main source of employment is through Closet Made, which brings some type of widget over there, thank you. And they put something together for Closet Made. That Closet Made brings some pallets of these things and they put them together and they ship them back to Closet Made. And I think you've got close to 90 people employed there right now. And in kind of what I've seen in our other partnerships, that if we can partner with people that have this successful plan or program, is there some way basically for us to partner with a guy like him that seems to be doing a better job of this than anybody else I've seen, and get these people better employment? I mean, he's hiring people that have felony records, and these people are having trouble getting a job anywhere else. Now, what happens when they walk out the door? I mean, they come in at 8 o'clock, they leave at 5, something like that. What happens when they leave his place? Some of them are still homeless. Maybe all of them are. I don't really know the answer to that. But I will say, from just taking a tour of it and talking to a handful of people that are employed there, that he's making a big difference in some of those people's lives. I mean, a real big difference. And if they are still sleeping on the street somewhere or in the woods, from what I can tell, at least they have, as Rich mentioned, they have hope. They are not in a state of mental despair that they were in. So, you know, for whatever it's worth, I'm not really, I'm dropping off the board here in another couple of months, but, you know, when next year's budget comes up, trying to allocate resources in the right direction at the most impact on years of life loss or mortality or life expectancy is what we should probably be looking at. That segment of our population, though, is no doubt a population that could pay dividends if we can solve some of those problems. As soon as you know, there's an old saying, I'm a real estate guy, as soon as you start getting in some real, you know, I'd rather own a warehouse where a guy operate a business there and he's paying me rent every month than own an apartment complex. Why is that? Because when people, there's an old saying in real estate, that when you start managing something where people sleep every night, the problems get a lot more complicated. So when you start getting into something where people actually are staying there and you have to manage that, it takes another level of oversight, let's just say, by think Kent Roberto or somebody couldn't do it. I'm impressed with that guy. But it is, whatever he's doing now is a lot different than what he is doing now, managing a facility where people are staying overnight. So I would be a little concerned about that.
Okay. Anything, Harvey?
Yeah, to see if any of our pillars can be put together to redo. And then I'd like to know if we're missing any gaps in our pillars. And that'll probably come when we get some of that education in our next meeting. And then I would like to get some feedback from existing agencies to see, as Michelle mentioned, what gaps they see a need for, and to see if we put those two things together. Those are my points.
Okay. So you have your ask of what you need to do for the next meeting?
So, yes, and also I will follow up after the meeting with each one of you just to make sure that, you know, our next meeting is really beneficial for our time, and that we focus on not only what we have and the consolidation, look at the, especially county community health assessment data, and make sure that the gaps that we currently have are still our focus areas, but also I will make sure that we have some input from particularly continuum of care. So, you know, from the homelessness standpoint, we can identify what they see since they live completed.
Okay. Anything else from the trustees? Michelle? Okay, before we go into public comments, we're going to go ahead and take roll call. So David?
Here.
Harvey?
Here.
Ken?
Here.
Rich?
Here.
Michelle, you with us? And I'm here. Right. So who's going to facilitate public comments?
I can facilitate public comments. So we have 4 individuals that have requested to speak to the public. Participants each have 3 minutes. We have a clock over here. We have our speaker here for you to speak into. I'll leave your thing up here so you can speak. You cannot go over the 3-minute time clock. If you do, it's just going to end what you're saying. Time cannot be extended or transferred to a different participant. So Webster is the first person that requested to speak. Are you still interested in doing? Okay. And Crystal is
Good
going
afternoon,
to.
everyone. My name is Webster Luciaga, owner of Latinos in Mass and Ipanema Residence Day House in Ocala.
Let me make sure it's not. That's okay, sorry.
First, I just want to tell you, to the trustees, that I commend your job, the projects that you are working on in benefit of the community. This is my first time that I hear, one of the workshops, and I'm very impressed. And I guess my questions are not at the right time, because I probably had, the impression that we're going to be discussing more indirect about the homeless situation and shelters, and maybe that's why I was a little bit concerned, because everybody knows that homeless we have a lot of issues with homeless in Ocala, downtown, shelters, and us especially having the hospitality business, we face unfortunately we see situations daily that affect our businesses and affect our customers, and sooner or later, it has to be addressed, because, creating more shelters brings more homeless to the area, and that's something that we don't really just want to have, if we're going to solve the homeless situation, bring ideas, we should always involve in the community. Find ways to just not create shelters, but be able to manage and train and do probably places with nurseries and vegetable gardens, or something that they can be trained and help them learn a skill that can bring them back to the working force in the community. But anyway, that was my questions, but I probably was not the right time to bring them. But maybe for the next meeting or so, when the homeless situation is addressed, then I'll be happy to be here. Then. Thank you.
And Stewart?
Hello, everybody, and thank you. I'm Leanne Stewart with Three's Catering. Three's Catering is a division of Latino Lamas and Campanima. The reason that my whole question was just what we were hearing out there. And what we were hearing out there was the fact that we were looking at the trustees purchasing a piece of property that would be for the homeless. Homeless is something that we really need to discuss. However, there was two things that were brought up today that I was questioning about. One is the homeless that the company Wears Gloves is dealing with. And then there's the homeless that was used as an example of, well, the person was on drugs and he walked across Pine, and did he get killed because of the car or because he was homeless? Or did he get killed because of drugs? So when you're talking about your pillars, that pillar really covers the mental as far as the drugs are concerned. Is this an issue? Does that homeless, if we do a separate pillar on homeless, then the homeless pillar needs to be a different division, and then you get into discrimination. So you're discriminating against which homeless person? Are you discriminating against the homeless that's on drugs? Or are you discriminating against the homeless that wants to work with wearing gloves and wants to be part of the community and wants to get back into it and into the work mode? So we got two different divisions there of homeless that I'd like to see addressed before you even consider, do we invest in it, do we have a pillar on it, or anything like that? Thank you.
Thank you.
April McDonald.
My name is April McDonald. I'm the director of Project Hope. This is not what I included to say today, but and based on what I'm hearing, I would love to be part of that conversation. I am one of the providers that serves a most precious and most vulnerable population. And so there are others in this audience that have a true heart and compassion for the homeless, and I can't speak for them, but I can speak for myself. I would love to be part of that conversation when the time comes. Thank you for the opportunity to take a couple minutes of your time. I come before you with no request nor critique, but rather a heartfelt thank you on behalf of the 80 mothers and children at Project Hope who are currently receiving on-site clinical intervention made possible by a grant through the hospital district. Because of the transportation challenges and multitude of other issues, many of our mothers transitioning out of homelessness found it near impossible to seek clinical intervention through partner agencies. Having this support literally on site has made more of an impact than I'm able to convey to you in 2 minutes. Just believe me when I say the service has added so much to the hope and healing that we are charged with ensuring on a daily basis. So thank you from us at Project Hope and for all you do for the most vulnerable in our county, whether that's through the multiple nonprofits that you support and serve, the school system, or other behavioral health organizations. God bless you all as you continue, each of you collectively and individually, to make a positive, necessary, and essential impact in our county.
Thank you. Thank you. Wyckoff? And can I collect these when you're done, just so?
Hi, everyone, how are you?
Welcome.
Hello.
I wanted to have Roger speak, but Roger couldn't find his teeth this morning, but he looks awesome. Wait till I get your pictures. Anyway, Roger is somebody who has been arrested over 150 times in his lifetime. He's been in and out of the hospitals 150 times here. He has been in and out of mental health centers. And he's been hit by a semi. That's why he walks with a shopping cart and limps. And they were going to amputate his legs. And then they were able to save him because he was in a coma. And then they got him, took him a year to learn how to walk. And then he was in a halfway house until the lady died. And then he ended up back on the street. So he's been on the street for 50 years. He'll be 4 years sober in July. And unfortunately, if 20 years ago, y'all had been at a table like this, jail to community, because I know I've talked to Michelle and the county commissioners. So much wisdom. Amazing. So much wisdom right now, I just heard. And the rest of the audience, I think we're having a divine appointment. So Roger would love to talk to you, also out of Marbuckle. Mr. Lind, top 3 recidivists in the entire county. They're all out of the system for the past 5 years. It can be done, jail to community, and then we need the rest of these folks. And we need y'all, because it takes money. It's not a simple problem, you all know that. And it is complex. But Roger, stand up.
Yeah.
That's what semis do when they run you over.
Hey, believe it or not, I used to dance.
I'll take him to the villages, I have a video. So Roger, he wants to know you, and that's proximity. And another great organization, because I'm always trying to get people to go on trips, is go meet Father Greg Boyle out at Homeboy Industries. Amazing place. Thank you.
Thank you.
Angie Clifton?
Good afternoon, everybody. Angie Clifton. I'm the area president for Main Street Community Bank, but I'm here today on behalf of the Continuum of Care and the Board of Governors. I co-chair the Continuum of Care and have for 2 years, as well as the Board of Governors. And I will tell you that when I joined both 2 years ago, I had no clue what in the world was going on. I joined because somebody tapped me on the shoulder and said, we need some help and we need some business leaders. I'm one of 2 business leaders that serves on the Continuum of Care and the Board of Governors. The rest of those boards are providers, just like April and just like some others that are in this room today. They're the providers that serve all of those in need, and they need business leaders. They need the talent that's sitting at this table, and I implore you to add homelessness as a pillar all by itself. And I ask you to please hear what Commissioner Stone says about looking into the Continuum of Care and your partnership. I will continue to be involved until the day I go to heaven. And I know that there are other leaders that would be involved if they felt that there were other business leaders and other leaders in the community outside of just those service providers, because they're working so hard and we need those that can make a difference. Thank you.
Thank you.
And that's it for public comments.
Okay, so the first thing I'd like to say is I want to thank every one of our community partners and the public that took time out of your day to come and join us today for the workshop. It means a tremendous amount to all of us here as trustees, so thank you very much.
Thank you.
Kurt, do you have anything else to go over?
No, I will follow up after this meeting and make sure that we are on track with all of the data. And what we will do is we're going to poll the trustees that are here and the 2 that unfortunately could not make it today. And we will come up as soon as we can with that follow-up meeting so we can try to post that and try to get an agenda as soon as we can so we can get that available so people can view that and see what we're going to talk about.
I will make a comment onto that. We want it sooner than later, but however, we don't want it to be a wasted meeting. We want you to have time to get the data needed to present to us so it will be a meeting.
Okay.
Okay? Anything else from the trustees? Rob, do you have anything you'd like to add?
No, ma'am.
Okay. Matt?
No, I'm sure.
Okay.
You don't need anything from me, believe me.
Okay.